Okay, this is our lecture on medical insurance. So I'm going to just briefly talk about some of these slides. Growth and change in structure of healthcare insurance has really affected American healthcare since the end of World War II. Canada and Western Europe were introducing government-provided care, and the United States turned primarily to the private market to provide insurance coverage to Americans. So the problem was that many Americans could not afford health insurance. And as healthcare costs increase, there was increased pressure to maintain high standards as a reasonable cost. Healthcare is just very expensive. So the history of health insurance, accident insurance began in the mid-1800s, and in the 1930s, a group of teachers arranged to pay monthly so hospital costs would be covered. And that's kind of where the basis for Blue Cross Blue Shield came from. The first insurance programs reimbursed on the basis of service provided, much like a fee-for-service, which is insurance reimbursement based on the fee charged and the service provided. And insurance became a tool for collective bargaining by labor unions. So they could offer that insurance as a benefit. During World War II, new clinics in California were created by Henry Kaiser. Capitation, we hear this word a lot. It's payment of a fixed amount monthly per member, regardless of the amount of care received. So, you may not be paying very much for health, or you may pay me and Arthur G might pay the same amount, but Arthur G requires a whole lot more care than I do. So it kind of even things out. The benefits of the original HMO movement. So let me go back to that capitation thing because it's kind of weird, but you can make healthcare affordable despite their health, but sometimes that can be abused. So it was just the same amount no matter how sick you were. So beliefs of the original HMO movement was restricting care to provide specific providers, or restricting care to specific providers and facilities lowers the cost of care. They hired physicians as employees, and preventative care is less expensive than when a patient becomes acutely ill. So the HMO movement became managed care in the last part of the 20th century. There were new forms of administration, and they wanted to trend away from self-run health facilities to use of community physicians and hospitals. So it kind of moved in a different direction. In the 1960s, healthcare costs began to increase faster than the general rate of inflation. So physicians were making a large amount of money. Employed individuals had health insurance through employers, and unemployed individuals found it very difficult to afford health care. They were low income, elderly, and permanently disabled. So Medicare was established as a federal insurance program to provide insurance for elderly and the permanently disabled and those who have end-stage renal disease. It's paid for by taxes on employers and workers. And then Medicaid established to provide insurance to low-income individuals as well as families. And it's even though it's federally run, it's administered by each state. So each state has its own name and criteria for eligibility. The VA offered medical care to veterans. Originally, patients had to have seen active duty. They had to receive care at a VA facility, but it did cover dependents and spouses, or dependent spouses and children of veterans with service-connected disabilities. So the government also provided care for dependents of active military personnel. It was originally called CHAMP US, and then it changed to TRICARE. We'll talk a little bit more about that. So at the beginning of the 21st century, American society is still trying to resolve insurance issues. The Patient Protection and the Affordable Care Act attempts to define patient rights and ensure that all Americans have access to affordable, high-quality health care, although I'm not quite sure how that is going. So obtaining health insurance, an employee can obtain health insurance through a group plan of an employer. They may offer a choice of several health plans. They may pay some or all of the amount for the insurance, and then the employee pays them a remaining amount. There might be family coverage, which may cost more to the employee, and then trade unions can bargain for improved health benefits at low costs to employees. Small business owners can purchase group plan insurance for employees through a trade association, and then individuals can also be eligible for group plan insurance through an organization like a professional organization or some type of college alumni association. Insurance plans also offer individual plans. They're usually more expensive. They're usually more limited to benefits than group plans are. And self-employed individuals can deduct that cost of insurance as a business expense. Government plans have eligibility criteria. So you're eligible for Medicare at age 65 if you've worked 10 years in Medicare-covered employment. Eligibility for other government plans vary according to your state. And you must file for Medicare or another Medicare type plan. Those don't just automatically start when you're 65. So paying for health insurance and health care, you have a premium. So a premium is the amount of money paid to purchase health insurance or any type of other insurance. It might be paid monthly, quarterly, semi-annually, or annually. It might be paid by the employer or the individual or both. A benefit is a service covered by an insurance plan. You may have wellness benefits. You may get immunizations for free. Those are examples of types of benefits. The cost of the insurance depends on the benefits provided by that plan. So usually the more benefits, the more costly. The employer portion of insurance is not included in the employee's taxable income, so it can't be taxed. And an employee may also be able to use a plan for health costs to be deducted before that tax as well. So some other key terms about member health costs under an insurance plan. Some have a deductible, which is a payment by the member each calendar year before health insurance pays for any services. So patient might be responsible for paying $500 out of pocket before their insurance will start paying for any services that they have. And the deductible usually applies to each member in a family plan. So if I have a $500 deductible, then each member of my family may have to breach that deductible as well before it starts paying. A coinsurance is the percentage the member must pay. So it may only apply to the amount allowed as a charge by the insurance company. So it might only be a 20%. So say the total of the bill is 100%, the insurance might pay 80%, and then the coinsurance for the patient might be 20%. A copayment is a fixed dollar amount the member must pay each time he or she receives services. And some plans, copayment amounts are different depending on provider or service. So an example of that might be if a patient goes to see their primary care doctor, they might pay $20. If they go see a specialist, it might be $30. If they go to an urgent care, they might pay $25 for a copay. Or if they go to the emergency room, maybe it's a $50 copay. So it just depends on the provider or the service the patient is receiving. Patient and member are going to be used interchangeably during this lecture too, just so there's no confusion there. So there's primary, secondary, and tertiary insurance. So an individual might be covered by more than one insurance plan. This can happen a lot with Medicare and Medicaid. And then there's an order to which plan will pay first, second, third, etc. So your primary insurance is the insurance to whom the insurance claim must first be sent to. So you go to the doctor, you have a claim that's generated from that visit, and then your primary insurance will be the first insurance to receive that claim. The subscriber is the individual named on the insurance certificate. If the patient is the subscriber, that insurance is primary. So my husband has insurance. He's the subscriber, so his primary is that insurance that he has through his employer. Secondary insurance is insurance that covers an individual in addition to their primary insurance. So a patient might be covered by their own insurance plus that of a spouse. So for example, I can have insurance, and then maybe I also have my husband's insurance. But I would be the subscriber to my own employer's health insurance. And then if I chose to get insurance through my husband, he would be my secondary insurance. If a child has parents who both have insurance, they might be covered by the insurance of both of those parents. Or a patient may have purchased some kind of supplemental plan. That can happen a lot with Medicare as well, where they have a supplemental insurance, and we're going to talk about that a little bit more. Sometimes a patient might be covered by a third insurance. That's their tertiary or the third place that claim would be sent to. Private insurance is usually billed before government insurance. So if I had insurance through my employer, but then I also had Medicare or Medicaid, my employer insurance would be billed first, and then Medicare or Medicaid would always be billed second. So coordination of benefits. So the term for rules insurance companies use to coordinate insurance payments, that is coordination of benefits. So all insurance together never pays more than 100% of a charge for a healthcare service. And the rules will depend on individual states. So there's problems if the insurance doesn't have coordination of benefits provision, and there's problems if a patient's insurance is from another state. So insurance obtained from an employer is the primary insurance. That's who must be billed first. So the insurance of a spouse will only pay for a portion not covered by the primary insurance. So that can include the deductible, the coinsurance, or the copayment. So if a child is the patient, then the birthday rule applies. So the primary insurance, what that means is that the primary insurance for a child covered by insurance of both parents is that the parents whose birthday comes first in the calendar year. So if my birthday's in November, my husband's in December, it would be me first that would make that insurance primary. So if a child's parents are divorced, there are different possibilities that can come about when it comes to which insurance is primary. So usually the court identifies which parent is the responsible party to provide that primary insurance. That court ruling can apply in either joint or individual custody. And if there's no court ruling, then usually the custodial parent is responsible if remarried. Or if no court ruling and custodial parent is not remarried, then the birthday rule applies. So a couple different instances there, but the responsible party, whichever parent is that responsible party, that's who's going to provide that primary insurance. An employee might be able to take cash instead of health insurance. So if there's a married couple and the wife has insurance for the husband, she may be paid a little bit more if she doesn't take the insurance, just as an example. Married couples usually only choose a family plan from one employer. So a married couple might look at the cost and the benefit of each plan and pick the one that has where they're paying the least amount and maybe has the most benefits. If a patient has Medicare as well as insurance through an employer, then that employer plan is primary. And if a person with Medicare purchases a Medicare supplement plan, then that supplement plan will be secondary. Usually those supplemental plans are like a Medicare Part D, and we'll talk about that a little bit more. So types of reimbursement that can be received. So under capitation, remember that capitation is the fee. I meant to leave that out. Capitation, just to review, is the payment of a fixed amount monthly per member, regardless of the amount. So under capitation, either a monthly, quarterly, or semi-annual payments are received. There's a specific amount per patient, and the fixed amount doesn't vary based on the care that's provided. So that places some risk with the doctor because you might be providing a whole lot of care if you have a very elderly, ill population. They may not be getting reimbursed very well because they're receiving a fixed amount no matter what kind of care they provide. Under fee-for-service reimbursement, the physician is reimbursed for each service. So each type of insurance pays a different amount depending on its fee schedule. So there's a difference between the charge and the payment is subtracted from the patient amount as an adjustment. So if I can explain that maybe a little bit differently. So my insurance and your insurance may pay differently depending on the fee schedule and what the charge was. So that charge, it's the difference between the charge that is submitted and then that payment that's received from that fee-for-service plan is subtracted from the patient account as an adjustment. So the patient is only due for they only pays a smaller amount. So fee-for-service plans, this is traditional health insurance that provides payment for each service received again. It's called fee-for-service or indemnity plans. Indemnity is obligation to compensate an individual for loss or damage. So originally Blue Cross Blue Shield plans were fee-for-service, and the patient usually pays a deductible and then a co-insurance. And that co-insurance is usually 20% of whatever that charge is. So the insurance would pay 80, the co-insurance to the patient would be 20. Insurance plan may determine the allowed charge through a fee schedule for all covered services. So there might be a set fee schedule based on where you live and the normal amount that's billed for a certain service, and then there's a set fee for that covered service. So also through fee-for-service plans, the insurance plan may determine that an allowed charge through usual, customary, and reasonable fees, or UCR. So this is kind of what I was referring to in the last slide. The usual fee is the most common charged by the office for a specific service. The customary fee is charged by other physicians in that same area. And then the reasonable fee meets the criteria of both of those together, or for other special circumstances. So the insurance company usually keeps their own statistics and they determine those usual, customary, and reasonable fees. And then that's what sets that fee schedule for whatever service is being provided. So everybody is being paid the same amount for the same type of service. They're being reimbursed that same amount. So with fee-for-service plans, the patient can usually make an appointment with any physician in any specialty. Sometimes full payment is limited with a list of approved physicians, like a PPO plan, and we'll talk a little bit more about PPO plans. But that's kind of how fee-for-service plans work, in that the fact there's just there's a service and there's a fee for that service, and then that's what the insurance pays, and then the patient might be responsible for that co-insurance amount that's remaining. So now let's move on to managed care plans. So managed care plans are types of HMOs, or health maintenance organizations. So HMOs have evolved into many different types of managed care plans. And managed care plans and HMOs are similar plans known collectively as managed care. Or HMOs and similar plans are known just all together as managed care plans. Keep in mind that you are going to learn more about insurance as you work with it. I still don't know all there is to know about health insurance. There are people that deal with this every day that you will probably be able to call if this isn't your job. So just know that you are going to learn this with time. I had to review a lot of this before I lectured on it, just because I don't deal with it all the time. So just a few little things for you to remember. Managed care is the movement to control health costs while involving preventative care, and a general term for insurance provided with these goals. So that's what the managed care plans try to focus on. Private insurance companies and government plans offer managed care plans, and there's usually more than one option for a plan. So there's different ones to pick from. With a managed care plan, typically how this works is a patient chooses a primary care doctor or a primary care provider. That primary care provider is the physician who provides the most care, and they determine what other services are medically necessary. So the patient might be restricted with this plan to only go to certain providers, or what can happen is there are tiers or different levels of providers at different levels of reimbursement. So your insurance may have tier 1, tier 2, tier 3. The higher the tier that you go, the more money you will pay out of pocket. So they might have a group of doctors that are all available at tier 1, but then if you go see a doctor who's listed in your tier 2 of your managed care plan, you might pay more money out of pocket to see that provider. So again, the patient might be restricted to certain providers. So usually the patient must pay a higher percentage for care outside the primary network. That's what I was referring to with those tiers. The patient might be subject to balance billing for care outside the primary network. So this balance billing, this is where you would pay more out of pocket. What that is it's the difference between the amount charged for the service and then the amount allowed by the insurance. So because you're at that different, you're outside that primary network, you might pay more because the insurance isn't going to pay as much towards that charged service. So say if you saw someone that your managed care plan covered or in that tier 1 and they charge it $100 and you are only responsible, maybe they pay 80% of that. If you did a balance billing where you went to somebody that maybe wasn't in that primary network, your insurance may only pay 60% of that, where you would be responsible for the other 40. So that's just that difference in the amount charged for the service and the amount allowed by your insurance. So again, your care is restricted to providers and agencies, and that restriction is based on who the insurance company has contracts with. So what agencies, what providers, what facilities. The insurance might require a referral from the primary care provider for services other than what the primary care doctor is providing for them. So usually the primary care provider authorizes any other care that they receive, and they work like a gatekeeper, and they don't really control access to health covered by the insurance. They more guide that practice. So it's common for them to send patients for consultations with specialists, to receive therapy, and expensive diagnostic tests. So I want to touch a little bit, actually I will later, on referral, because I think we talk about that again. Yeah, okay. So let's move on and talk a little bit about HMOs. So the original HMO, this model is based on that capitation method of payment with the patient responsible only for a copay. The primary care provider acts as a gatekeeper. The service limited to HMO and hospitals with which it has contracts with, and preventative care is typically covered. HMOs are incorporated and they are regulated on a state-by-state basis. So HMOs usually require more care measures than other insurance companies, and they usually only operate in one state. HMOs regulate the way member physicians provide care. So HMOs might do physician audits to review how expensive tests are used. Whoops, I'm sorry. I'm skipping around here. So with these HMOs, they usually have a more comprehensive quality assurance program. And so that leads in a little bit more to the reason they do audits. They want to make sure that things are being done as they are medically necessary. There's usually a referral procedure, and it can be in written form, online, or verbal. This is rare, but I still hear a lot of verbal referral processes. They usually require pre-certification by the HMO for any kind of surgery, and then usually some other procedures, and we're going to talk about that pre-certification process too. When you pre-certify something, there's an authorization number that you get that will be required for you to pass along. They may restrict the use of laboratories or hospitals, so they may limit where you can go to have things done. And it's important that you're familiar with requirements for each type of insurance. And again, that's something as you're going to learn as you work as a medical assistant. It's not something you're going to know immediately. So I'm going to buzz through these real quick. There's a staff model HMO. It's the least common. It's where the insurance company has its own medical offices to provide care, and physicians are employees, and the patient must receive primary care in those planned facilities. The Network Health Maintenance Organization, it's where the HMO contracts with physician groups within the community. Typically, the member physicians also accept other insurance, and patients in the HMO must be referred to network providers if possible. Out-of-network services only allowed for emergency or urgent services. And then there's other types of managed care models that are incorporated as insurance companies. They're not HMOs, but they have features that are in common with that. So again, not something that you necessarily need to know, but just a few things so that you've heard it before. Preferred provider organization, so PPO, this differentiates between in-network and out-of-network services. So the HMO had tiers, I think it was. Now we're looking at in-network and out-of-network. And there's financial incentive for patients to use providers in the network. So if you use this provider, we're going to pay your 100% of your bill. Usually there's deductibles and coinsurance. And then the deductibles and or the coinsurance may only apply to out-of-network services. It just depends on the plan. And the patient pays a higher percentage when they seek care that's out-of-network. So this exclusive provider, this is similar to a PPO, but it's only in-network services are covered, and if you go outside the network, it's not. So again, these couple next slides are just going to be quick, just to mention. Independent practice association are where physicians organize a physician association, which becomes that insurance plan. Physicians are paid from funds that are collected from the subscribers, and the physicians association retains administrative costs, marketing and sales costs, and overhead costs. Oops. Just hit that button ever so slightly. The patient pays a higher percentage for out-of-network care as well. Oh, sorry. They have a holdback or payment that's made to member physicians only if there's money left over after costs have been met. So it seems a little risky to me. Point of service plans, that's an in-network plan regulated as an HMO with an out-of-network plan regulated as an insurance plan. Very confusing. It's similar to a PPO except for that and how that in-network plan is regulated. Members have 2 certificates, one for the HMO and one for the indemnity carrier. And then members have a higher financial obligation when they seek out-of-network services. So again, just a few things for you to know. Medicare is a little bit different. Lots of Medicare in the world. It's federally funded. It's administered by the Center for Medicare and Medicaid Services. That's known as CMS. And how you know you're eligible for Medicare is that you are retired older than age 65. And then there's some railroad employees and some federal employees as well that are eligible for Medicare. Also some eligibility requirements. If you have been permanently disabled for 2 years, you can then qualify for Medicare. If you are blind, if you have chronic renal failure and require dialysis or a renal transplant or kidney donors. The reason that those patients with chronic renal failure who are receiving dialysis, they go to dialysis 3 times a week. So it's very hard for them to work. And those patients incur a lot of costs when it comes to their health care. So that's the reason that they are eligible no matter what age. If they're on dialysis, they can be eligible for Medicare. So the original Medicare plan, so there's different parts. So there's Part A, that is for hospital services. There's Part B, this covers office visits and equipment. Most all Medicare patients have A and B. Part C is those new, they're the new Medicare Advantage plans. They were introduced in '97, but they are really starting to be more popular now. And they include like a managed care plan. So it's more like a commercial insurance. Part D went into effect in 2006, and this Part D plan is usually a prescription drug benefit. So what happens is when a patient turns 65 and they're eligible for Medicare and they're retired and they want to go ahead and enroll in Medicare services or for Medicare plans, there's an open enrollment period. It usually starts like early October, I think, and ends early December. There are, I don't know what they're called, but there's people who are available in the community, usually that work for like the health department, that can help patients choose the Medicare plan that is going to best fit their needs. So a lot of times they look at the medications they're taking, how often they visit the doctor, if they see specialists, and then they can kind of help work with them to see what kind of plan would best fit their needs. So let's talk about this a little bit more. So there's no cost to have Medicare Part A. You can just enroll and receive Medicare Part A. Usually the first day of the hospital admission is not paid by Medicare, and that acts sort of as their deductible. But Part A is funded by tax on working individuals. So this is what we pay for all of our lives. You must apply for Part B or for a Medicare Advantage plan, and with that you pay a premium, which is that cost we talked about earlier. The fiscal intermediary, that's an insurance company that contracts with Medicare to process those claims. And there's one assigned for each state or each geographic area. This is what the red, white, and blue Medicare card looks like. It'll have their name, their claim number, and then if they have Part A and Part B. So that's what you would see when someone brings in their Medicare card. Payments for Part A are based on diagnosis-related groups. So remember we said Part A was the hospital services portion. Those DRGs are a system that classifies patients according to their diagnosis, the treatment they receive, and how long a patient stays in the hospital. So hospital patients, each of them are assigned a DRG, and then Medicare pays based on that DRG, not that actual length of stay. So this is why hospitals want to get patients well quickly, because they're paid based on the diagnosis that the patient is in for, not how long they're in the hospital. So if patients go in with congestive heart failure, it doesn't matter how long they're there, how short of a stay they have, they're going to be paid based on that DRG. So that's why hospitals have such a, they like to be on the ball and get patients the care that they need quickly, so that that length of stay, that hospital's length of stay might be long, and so that reimbursement may not pay for their whole hospital stay. So payments for Medicare Part B, those are based on RBRBs, or resource-based relative value scale. So this is a system of reimbursement that assigns relative value units to procedures on the basis of the amount of work, overhead expenses, and costs of malpractice insurance. This is adjusted by Medicare for each geographic area every year, and there's an online fee schedule available that sets the maximum allowable charge for office procedures. So it'll give a set amount that a physician can't charge anything higher than their set amount. So physicians can choose to participate in Medicare programs. Most do. If they do participate, they must accept the assignment of benefits and the Medicare determination of the allowable charge. So they must say that no matter what I bill, Medicare is going to determine that allowable charge. So if a patient pays an annual deductible of $135, and this is what was accurate in 2008, and then they'll pay 20% of whatever that charge is. So kind of like that, how that co-insurance works. If a patient or if a physician doesn't participate, then they collect the fee from the patient, and then Medicare will reimburse the patient. But it's only for the allowable charge, not any more than that. So the physician can't bill them more than what Medicare allows. I skipped that. Did I skip one? I did, didn't I? I skipped two. No. Okay. So Medicare supplemental insurance is available. And this supplemental insurance usually covers the first day of a hospital stay. There's an annual deductible and then a 20% co-insurance that they pay. Supplemental insurance is usually not necessary when they have the Medicare Advantage plans. If Medicare is primary, then patients usually want to consider a secondary insurance. So Medicare would be their primary, and then that secondary insurance would be that supplemental plan. If a person continues to be employed after age 65, then the insurance is through their employer, is their primary insurance. Okay, now let's talk about Medicaid. So The federal government provides grants to each state to administer the Medicaid program in that state. And then the state also funds part of that program. So the name of the program, who is eligible, and those specific benefits and requirements will vary from each state. So what we have in Illinois will be different than what is in Missouri and Indiana and Ohio and everywhere else. It is important that we check Medicaid eligibility at each visit. Physicians can accept or refuse Medicaid as an insurance as well. If a physician accepts Medicaid, then they must accept what Medicaid pays as payment in full, just like Medicare. Patients make no payments or co-payments. And patients usually who receive welfare or some other type of assistance usually receive Medicaid, although I'm not sure that that's accurate. Medicaid also covers nursing home costs for some elderly and disabled patients. So nursing home benefits account for the majority of Medicaid payments, and an individual only becomes eligible when personal resources fall below a predetermined level. So patients who get Medicaid who are in the nursing home usually have absolutely nothing left. It's a crazy process for patients to get Medicaid to stay in the nursing home. So if an individual has both Medicare and Medicaid, then Medicare is that primary insurance. Medicaid will cover the same cost just like a supplemental insurance would. So Medicare usually covers 80%, and then Medicaid or the Medicare supplement will cover that 20%. So this is kind of like how this crossover claim works. An insurance claim that is automatically processed first by Medicare and then sent directly to Medicaid to pay that remaining balance. So children's health insurance programs. Again, each state has a program to provide insurance for children whose parents can't afford health insurance for them. It's funded by federal and state governments. In some states, children are enrolled in Medicaid, and there's a separate program in others. So it just kind of depends where you're at, what programs are available. It was reauthorized and expanded in 2009 and then extended again as part of the Affordable Care Act in 2010. Insurance plans for dependents of members of the armed forces and veterans. So TRICARE is what our military has. They provide health benefits for spouses and children of active military personnel. And there's 3 different types. It's going to be important that you know those 3 different types. There's TRICARE Standard, which used to be CHAMP US. It's the traditional plan. And then there's Prime, which is like an HMO, and then there's Extra, which has additional network benefits available in addition to that standard plan. Workman's Comp. There's a program in each state to cover medical costs and lost wages for those who are injured while they're at work. And the cost of that insurance is paid by employers. The premium that is paid by employers usually depends on on claims prior. So previous claims by employees of a specific employer. It's important that if someone is injured at work, they make a prompt claim for their workman's comp. And in many states, employer and workman's compensation insurance must approve the physician, or they may choose to have a physician treat the injured worker. So it depends. You may be required to see a certain physician if you have a workman's comp injury. So it's important to check with the patient's employer promptly if someone states that they have a work-related injury. You want to make sure that the patient has filed a claim. That way they have a claim number, and that's where all of that billing will go through. And it's also to be sure that the medical treatment will be covered by workman's comp. You don't want to just start accruing all these costs and then the employer isn't going to pay for anything. The patient's stuck with all of that. You want to establish a separate medical record for those work-related injuries or conditions. So only that information about that condition should be submitted to the workman's comp insurance. Information that may be required to determine benefits or process an appeal. So if a patient is being seen for high blood pressure and they also have a back injury from work, you would address the hypertension. Is that what I said? High blood pressure? I hope so. You would address that medical condition of hypertension in the regular chart, and then there would be a separate, like in the electronic record, there's a separate portion for workman's comp where all those records go in there. So the physician would actually have to document in 2 different spots. So usually you want to keep those visits separate from any kind of checkup or sick visit. You want to just keep those workman's comp visits just specific to that work injury. So the physician must file the first injury report, and there's 4 copies of that. It has to be done within 72 hours. And then the physician must submit a statement of services and monthly reports. And then the physician must accept payment provided as payment in full. It's important to be familiar with the requirements of each insurance carrier and HMO. Usually handbooks are given to providers, and you want to know which lab can do work, which pharmacies. Again, I tend to think that some of this falls on the patient. For me, it's helpful to know which pharmacy I can go to because it's cheaper for me. Sure, you might need help figuring that out. The patient might. But I think working together with the patient is very important. Insurance is very hard to understand. We have trouble understanding it. So you can imagine that for a 70-year-old person, it might be harder too, or someone who's 80. It's just important to just make sure you're aware, and that you know, what can be submitted with the help of the patient. So when you verify eligibility, let's talk about some of the terms that go along with this. So when you verify eligibility status, you're determining if a patient has health insurance coverage and if they will be able to receive health insurance benefits. So you want to check their insurance card. There's usually a phone number or website to visit, and then you can verify that the patient is eligible. You also want to verify their insurance benefits. So does the patient have insurance to cover the proposed service? So if you are seeing the patient today, and it's still May, but they are going to be getting some type of procedure in June, you want to make sure that the patient is still going to be eligible with their insurance. They're still going to be active with that insurance in June as well. So pre-authorization. So pre-authorization can have a lot of terms with it. So pre-authorization, pre-certification, prior auth, pre-cert, those are all terms that you're going to hear. So this is a term that indicates that the patient's insurance company has verified that the service is covered by the insurance company. A lot of times this has to be done before any kind of procedure. But basically what is happening is that insurance company has reviewed what is being ordered, what procedure is being ordered, and has agreed that it's medically appropriate for the patient. Some companies are going to require formal notification. So it's important to make sure that if something needs a prior authorization, a pre-cert, whatever it may be, that that's done. It's our responsibility to get that completed so that the insurance company is going to pay and the patient isn't left with a bill. So the medical assistant, as the medical assistant, you are going to want to get information so that you can request that pre-certification. So you want to know what service is being provided, the diagnosis that correlates to that service, relevant information that justifies the need, so what's the documentation, and then the proposed date of service. And then you're going to want to provide the patient's demographics, so their name, address, birth date, phone number, insurance information, as well as the NPI. The NPI is the National Provider Identification Number. This correlates with your doctor. So each doctor is given an NPI number because there's 100 John Smiths that might be physicians. So if they have this one number, it is able to identify that specific physician. Referrals. So referrals are a little bit different. So referrals are directing of a patient to a medical specialist by a primary care physician. And the doctor might initiate a referral to a physician who participates in the patient's managed care plan without prior authorization. So again, that's consistent with the doctor's role as the gatekeeper. So in the office, we hear referrals a little bit differently. Referrals might be used as the doctor refers the patient to a different physician, or there might be an instance where you get a referral from the insurance company. So a referral might be used as a term in the office separate from something that's related to their insurance. We want to talk about what's needed with insurance. So do you need a referral to go see a specialist? And that just requires communication with the insurance company to make sure things are medically necessary. So fee-for-service insurance plans or Medicare, there's authorization for a specialist is not required, and it's usually a self-referral is the term that's used with that. So insurance claim forms. We're going to kind of skip through a lot of this. So the most common claim that's used in the medical office is the CMS 1500 form. It's required, it's the required form for Medicare claims, but it's accepted by most insurance as well. And then hospitals use a different kind of form. These are usually completed, it's accepted by most insurance companies as a universal claim form. It was updated in 2005 to accept that national provider identifier number. It's 10 digits, and it's unique for each healthcare provider. It replaces all previous provider numbers, and it was updated in 2010. So this is usually completed by using a computer program, and a lot of places now are going to prefer electronic submission of claims. If you're using a printed form, you're going to use uppercase letters that should be used without punctuation so that it can help with scanning. We are going to skip through how these are filled out. This is what it looks like. If you use these, the office is going to train you on how to fill these out. But there's information where you will provide the patient information, the insurance information, the claim, the data service. All of that information is going to be supplied on there. The doctor information, but we're going to just skip through this. Again, there's another picture of it. If you want to look in your book, it's on page 1203. You can take a glance at that. Electronic claims are usually faster. They go to a clearinghouse. A clearinghouse is a company who forwards claims information from healthcare providers to the insurance. So they're kind of like a middleman. And they can check for errors in the claim and then verify compatibility with the payer's software. So probably an extra charge, but might be worth it to maximize reimbursement. And then the procedure depends on the software in use. It's more accurate than paper claims, but you still want to keep track of what claims you're submitting. So someone in the office is going to be responsible for that. And then again, the paper claims is going to use that CMS 1500, and you want to make sure that paper claims are accepted to that insurance company before they're submitted. Again, capital letters, no punctuation. Make sure you're proofreading and that you're submitting them every day depending on your volume. If you are tracking reimbursement, so under capitation, the monthly, quarterly, or semi-annual payments that are received, there's going to be a specific amount per patient. Again, that fixed amount doesn't vary based on the care, and again, it puts some risk with the physician. With fee-for-service, the physician is reimbursed for each service, so each type of insurance is going to pay a different amount depending on that fee schedule that's set. And then the difference between the charge and the payment is subtracted for the patient account as an adjustment. So if the patient is going to owe $100 and you submit the charge to the insurance pays $80, you're going to apply that $80 to the patient account as an adjustment, and then that payment that's going to be left is the $20 that the patient's responsible for. Claims register is just a way that you keep track of the insurance claims, and you're going to keep track of the number, the patient name, what insurance company they use, along with their group ID number, or their patient ID number and their group number, and then when you submitted it and how much the claim was for, the date it was paid, and then how much. You can keep it manually or on the computer. You want to review that periodically just to make sure you're following up on anything that needs to be followed up on, and then see if you can figure out, a pattern of anything that's rejected so that you can just keep your claims up to date, and that you're following up on anything that maybe you can make better. If you're getting rejected claims on a specific thing, maybe you can improve that. That's kind of what maybe it would look like if you used something on paper. Remittance advice or an explanation of benefits. So if a payment or rejection of a claim is accompanied by a form, and it'll give specific information why. The explanation of benefits is used to enter information on the patient account, and it gives reasons that the claims are denied on the form. And this is kind of what that might look like. And there's a picture of this too on page 1211 in your book. Common errors. So why might a claim, or common errors on an insurance form? So examples of transposing names or numbers incorrectly. Maybe you reverse the name of the patient with the subscriber. So maybe I'm the subscriber, but the patient is my son, and you flip that around. Maybe you reverse the primary with the secondary insurance, and maybe you incorrectly transposed one of the identification numbers. So that can be one of the errors that come on this remittance that you might see. You might be missing signatures or the NPI number. Maybe you forgot to check a box. Maybe there was no prior authorization number listed on the form. That might be other reasons. Incomplete codes or inaccurate codes. Maybe you're missing some modifiers, or the diagnosis code isn't as specific as it could be. That might be another reason for an error or remittance for a rejected claim. Maybe information doesn't match codes on other information, so maybe inconsistent with gender, maybe the diagnosis code, the total amount of billing doesn't agree with the services, or there's a place of service that's inconsistent with the procedure code. You want to make sure you follow up and resubmit those claims as soon as possible. Or follow up with insurance if the claim isn't paid promptly, or if the claim's denied, and use that claim log to be sure all the claims from the same insurance are included in any inquiry. So just making sure you're getting everything you need. So effective communication regarding the managed care or insurance. So you want to make sure that you are familiar with that patient's insurance plan, or try your best to be, or help them to be familiar. You want to make sure you request specific information if anything's denied. Patients can really be upset about gaps in their insurance or when they owe a large bill, just because that's a lot of stress if they have a lot of medical bills and they're not sure how they're going to pay for that. So any way that you can communicate with your patients, in a calm manner and be helpful to them is going to be very important. So helping them to understand is going to be very important. So understanding yourself as you work in the field is going to be helpful. And that is the end of our discussion. Thanks for listening.